IVF Jhb provides an exclusive rehab treatment for alcoholism and drug addiction. The only rehab in South Africa that offers a medical detox treatment. We offer a superior, evidence-based and medically cutting-edge approach to the treatment of addiction. If you have been frustrated by repeated failures at rehab recovery or are unaware that there are proven anti-craving medications that can significantly improve treatment outcomes, give us a confidential call to learn more about IVF Jhb's rehab program. Contact IVF Jhb on 07827229111 24 hours or call our office number 031-261-5515 and our Johannesburg number on 0622770911. Office number 011-656-0705.
My name is Nelsi Wembata and I'm 33 years old. I'm from Ndlovu in a rural area. I'm an electrical apprenticeship at Tongati Hewlett. The late Mr. Mzobanzi Chili, who had been working in the local rural area, he told me about the internship at Tongati Hewlett. After inquiring my document, I applied in 2020. For more than 10 years, I've been at home without nothing and it's not easy to find jobs. This opportunity means a lot to me. It changed my life and it restored my self-esteem again and my self-confidence. My family, they are so happy because I'm the first one to get this opportunity. I'm growing a sweet future by inspiring a youth or a young one to study and to reach out. Thank you a lot, Tongati Hewlett, for giving me this opportunity. I'm growing a sweet future.
Good day and a warm welcome to African Essence. I'm your host, Sainashia Singh, and today we are at the Vitalab Fertility Clinic in Sandton, Johannesburg. Vitalab is a Johannesburg-based and Umhlanga KZN-based fertility clinic that has been assisting couples to build families since 1984. Vitalab has a saying that you arrive as a patient and leave as a parent. This place has been changing lives and giving you hope for a family. Joining us is Dr. Chris Venter, an IVF specialist here at Vitalab. Dr. Venter, thank you so much for joining us today.
Thank you, Sai, and thank you for this opportunity. It's always great to talk about our passion and what we're actually doing here at Vitalab. And like you said, trying to change lives and improve patients' lives in becoming parents.
So Dr. Venter, with regards to the types of patients that you see, could you tell us a bit more about the most common causes of female infertility?
Yeah, when we look at Vitalab and where it is situated, obviously we are at the tip of Africa. We do see people that travel cross-border for fertility care. And it actually just makes you realize how the need is there out there for people just to start their family and to complete their family. So we would see patients that travel cross-border. We see a lot of African patients coming from other African countries, and they usually would present here with, for years, I wouldn't say neglected, but not the right diagnosis made. And usually they will come here with severely affected uteruses, especially in African women. We do see that they do tend to get fibroids in the uteruses, and that we obviously had to go and fix the uterus first before we can start with fertility treatment. We also see a lot of our Indian patients as well, and then we know something like polycystic ovarian syndrome is very common in their genetics, and these women we would then go and treat first for their weight first, and then to start treating them for ovulation induction. When we look at our younger patients, we tend to see younger ladies coming, and usually these patients will come with a classical history of very painful periods. They've been from one doctor to another, and then just complaining about these painful periods. Then they get married, and then for 2 years they're struggling to conceive. So these ladies will usually present with what we call endometriosis, and it can be in different stages, but we need to make a diagnosis. And we also do know that endometriosis in 20% of our patients will cause infertility. So in these patients, usually we would go and operate just to try and clean these pelvises, and then give them a natural chance to try and conceive naturally. And also to have to talk with them as well on someone with a lower egg reserve and slightly older ovaries. They do tend to take longer to conceive. And these are the sort of the common patients we would see. But we do realize that in 20% of our couples, we don't actually find anything wrong. So husband has got a good sperm count, patient is ovulating, she's got open fallopian tubes, she's got a normal uterus, and she is not conceiving. And for that group, 20% of our population is what we would call unexplained infertility. And there is obviously certain things that we would go and recommend treatment for them as well.
Sure. And so we've discussed causes for women infertility, and of course one knows that women face a large amount of stigma and pressure when struggling to conceive naturally. Are there causes for male infertility, and could the husband actually be the cause of infertility in a couple?
Yeah, Sai, that's a very important question, because we made it a point that we won't see a female on her own. Her husband needs to come along, because it takes two to tango, and from the start his sperm is tested. We do know in couples there is in 60% of them there is usually a combination of issues, maybe a low sperm count and an ovulation issue. So it is paramount that we look at our males right from the start and not just focus on the female. So when we look at males to say how can we assess male fertility, obviously we'll do a standard sperm function analysis just to look at the certain parameters, and usually what we look for there is to look at the concentration of sperm within the semen that is given. We would then go and look at the motility of the sperm, and then the last thing is we would go and look at the morphology of the sperm, how the sperm is looking. We do know that if sperm starts looking abnormal, the DNA of the sperm can be affected and can also affect the ability of that sperm to fertilize an egg as well. And then the next question will pop up from the husband to say, but why is so many of my sperm looking abnormal? And I think there we need to look at just the environmental factors. Okay, what is causing sperm to start looking abnormal? And it's usually just sperm, how it's been stressed. So if a sperm is stressed, it starts changing its shape, and when it changes its shape, we know the DNA of that sperm is also changed, and that will compromise its function. If you look at just environmental factors, what can this be? Smoking, we know, is a big cause for subfertility. If we look at obesity, obviously men, once they get married, we're all having a good life, the married life, and we do pick up a bit of weight, and that overweight can also affect sperm quality. And then you can also go back as to say, well, okay, what happened to you as a child? Maybe you had mumps early on, maybe you had chemotherapy as a young cancer survivor, and you would go and look at what caused the toxicity of the sperm as well. We usually classify it in the following. We say, is it obstructive? So is the sperm not just coming out? So it's been produced, but it struggles to come out. And is there maybe a blockage in the tubal system? Or the other thing, is there the problem in the production? And I think in most of our males, the issue lies within the production. And again, like I said, primarily in the testes, if you have damage done to the primordial germ cells, which is producing your sperm, either in a form of infection or trauma or just stress, that will reflect in your sperm test.
Okay, and you know, as you mentioned, these reasons for a couple not being able to conceive, with regards to the emotional trauma that a woman and a couple may face, are there any support structures in place for that?
Yeah, there is support structures. I would maybe just like to come back to that first point you made of the social isolation, the stigmatization, where you hear horrific stories of young ladies that's been pushed aside in their communities, and it almost gives them this feeling of helplessness, something as basic as giving children they can't do. And I do think we sometimes do miss those opportunities. We do give them counseling, but I don't think people are always that forward in talking about that. And I do think in South Africa there's so many cultures, there's cultural differences as well, and I think different cultures treated people different on sort of isolating them or not talking about them as well. And if you talk about counseling, so we do support counseling by social workers and psychologists. The problem is just always people not seeking and say, well, if I get pregnant, the problem is solved, but there is a big psychological impact due to that as well. And I do think there needs to be more attention out there as well, especially looking at the cultural differences, how we can address these issues, and starting to train more psychologists in this field of fertility care.
Okay, and regarding infertility, what treatment options are available for patients and what is the success rate?
I think, Sai, what is very important, I think this is where when your journey starts, you need to ask your doctor, what is the cause of my infertility? Okay, so I do think it's all about getting the right information first. Like I said, in 20% of the couples, it's unexplained. We don't know why, but in 80% of the times, we can give a couple a reason. This has been the issue. Because again, going back, people will start blaming themselves. Maybe I'm doing this wrong or that wrong. 80% of the times, there is a reason why they cannot conceive. So when we start looking at the treatment of subfertility or infertility, is we would obviously go and treat what the cause are. So if it's endometriosis, we will then set up and do a laparoscopy, keyhole surgery, and go and treat the endometriosis to try and maximize the natural ability of that female to conceive. But again, if it does not happen, we must not do repeated surgeries, because this can also be harmful. So very importantly, in someone with endometriosis, to say this is the plan, surgery. If you do not conceive within a year, then we move on to either intrauterine insemination or IVF. So there always needs to be a clear plan for these patients. What are the goals? And if it's not reached, we move on to the next step. And that sort of motivates them, and it sort of empowers them as well to understand the whole process. If we look at someone that's just having polycystic ovarian syndrome, she's not ovulating, well, then we start off with ovulation induction tablets, and there's many protocols we can use to get her there. And then lastly, if you start looking at something like tubal, let's say the patient's got blocked tubes, you can go and do tubal surgery to try and open up these tubes. But we also know that the success of that is fairly limited as well. And if you've tried it, if it doesn't work, don't tell the patient to go and try. Just tell her it was not successful, and rather to move earlier on to in vitro fertilization. Another point, what we would see in couples where they would have this very severely fibroid uteruses, again, there's surgeries indicated there as well. One point that I do want to make as well, where we say, well, it's not an open end. You don't have years of doing this as well. And this is usually where we are confronted with older patients, women of the age of 38 or 40. We don't have time to wait. There we need to go in for very effective treatment strategies as well. And when I talk about effective treatment strategies, we talk about in vitro fertilization. So the question is always, why is it so successful? And what is a success? Part of your question. And that's all being determined by the quality of the female's sort of eggs as well. But if we do in vitro fertilization, is we would want to stimulate that female to produce as many as eggs within one cycle. We do know a female will only produce 1 egg monthly. Trying to get to the golden egg might take months, especially in the older women. So when we do IVF, then we stimulate them, we get 10 or 12 eggs, and within that we hopefully can find the golden eggs to use to be fertilized in and used for in vitro fertilization. So that is something that we can do to speed up the process to get to a pregnancy quicker. So I do think it is important, if you do the treatment, make the diagnosis, do the right treatment, and just implement it according to a roadmap for the patient. So the treatment, what we would call assisted reproductive technologies, what can we offer? It's ovulation induction for the women who do not ovulate, tablets for that, and then they will do timed intercourse, where there is a sperm factor, or even when the woman does not ovulate and there's a sperm factor, to say, well, let's consider artificial insemination. So stimulating the patient once she's about to ovulate, to get the husband's sperm, to process the sperm, use the best sperm, and then inject it close to where the ovary is. And in more complex cases like in vitro fertilization, and this is usually where people will have long-standing infertility, have blocked tubes, have poor quality eggs, or advanced maternal age, or very poor quality sperm, where we do know that these sperm cannot fertilize an egg. Then we utilize a process called ICSI, where we would actually take a sperm and inject it within an egg. So those processes as well, if you look at success rate of in vitro fertilization, it's anything between 40 to 70% per treatment cycle, depending on a few factors, obviously, as well. So, and I think this is again what you need to relate to your patients as well. You need to manage expectations, to tell exactly this is your chances. It's not 100%, but when we do IVF, at least we learn a lot as well. We learn a lot about what your embryos looks like, and maybe to help us in future as well. If it's unsuccessful, what can we do better in the second cycle?
You mentioned some key factors that I just want to touch on. Could we talk a bit more about donors, sperm donation, and surrogacy?
So in South Africa, about 95% of our egg donors, the donor cycles that's been done in South Africa, it's anonymous. So these are usually young ladies during university or students that decided they have a good egg reserve and they would like to donate some of their eggs to someone in need. So usually it is anonymous. The question will always be from the recipient couples is, who are the donors? Obviously we can't share their identity, but one thing they do know about them is the following: to know what is their physical characteristics. So these donors will fill in their height, their hair color, the eye colors. They'll also fill in some social issues as well. What are their interests? What are they studying? What is their cultural background, their religious background? So fill in all of this. So the recipient couples at least have some idea about their interest and their character. What we would do from clinicians is to make sure that these egg donors are screened for the following. We know socially they cannot smoke. We do screen them for any substance abuse. So there is a screen test they will do. If they use any illegal substances, it will be picked up in those tests. And then just verbally, we will screen them for genetic sort of abnormalities or genetic conditions that might be hereditary in their families. We also look at them medically as well. They need to be fit. They need to have no chronic illnesses. And then obviously when we screen them for their fertility, we want to make sure they've got good quality eggs as well. So this is the way we screen them, and then we would stimulate them, and then usually we will go and bank these eggs. Any other identifiable information as well, up until the age of 12, you can have see some photos of these young girls, how they looked up until the age of 12, but no adult photos. And this again is just to try and protect the anonymity of them as donors, and obviously these donors will also not know where the eggs are going as well. So it's very anonymous, and this is still stipulated in the law as well. There is known donors again, and there's obviously, once you start donating, to someone you know, you need to go for a psychological assessment, both parties as well, just to know what your long-term impact might be if you do decide to donate. When you look at sperm donors, it's slightly easier, same profile that we would go, same way we would screen the sperm donors, and they will also be screened according to their sperm parameters. So looking at this is good sperm parameters, it should be ideal for him becoming a sperm donor as well. In South Africa there is legislation, obviously how many times can a donor donate. So currently, as national guidelines stands, they can only, egg donor can donate 6 times. A sperm donor can donate more, and they are also looking at sort of extending these sort of guidelines as well. But currently, for a sperm donor, 12 live births, and then he needs to stop donating. And for a egg donor, 6 donations. I'm going to say something about surrogacy, and I think surrogacy is almost like egg donor as well. It's the last option for patients, because any woman in her life obviously want to use her own biological material, and all women in their lifetime would want to carry their own babies. So once we start moving to something like egg donation, this is the last route. The patients have tried their own eggs, didn't work, and now we're moving on to that as well. So that is towards the end of a long journey, and I do think it's a very big psychological journey as well, getting there as well. But once you've closed the chapter on your own eggs or your own uterus, where women might have had multiple failed attempts with her own uterus, then we will start consider surrogacy. So the way that surrogacy works is that, and again, it's you as a recipient couple or a commissioning couple need to find someone that will be willing to be a surrogate for you as well. If you do find such a person, and they're not readily available, it takes quite a journey to find such a person that will be able to carry your pregnancy. Once that person is found, we will then assess the potential surrogate. So we assess her for the following: to make sure that she is medically fit to carry another pregnancy, her uterus is normal and can also carry another pregnancy, and we will then send her also for a psychological report as well. Once all this is compiled, then we involve the legal lawyers that will take this case to the High Court, and a surrogacy order will be submitted for about 2 years, where this surrogate can carry this couple's embryos or pregnancy. So it is quite a long process, and again, a lot of legal costs, a lot of emotions going in there as well. But again, you would need to look at what's your end point. Your end point obviously is holding your baby right at the end of the day. So and I do think it's part of the fertility specialists, part of the fertility nursing staff, our social workers, to keep these patients motivated and just to guide them and to support them right through this very long journey.
Thank you, Dr. Venter. Now, this is such a complicated process, as you mentioned. How do the soon-to-be parents prepare themselves mentally and physically to go through this procedure?
Yes, like I said as well, you need to empower them with the right information. You need to tell them exactly what's been going on, inform them of the success rates, and I do think once your patient is informed, they buy into the process as well. And be honest, if it's not going to be an easy process, be upfront. But obviously you need to give hope, and you need to motivate them as well. So it is a fine balance. I do think it's very important to pick up the points when some people are losing hope, and I think there's a fine line, because sometimes they try and stay strong in front of you. So sometimes we would say, maybe go and see our psychologist. And having said that as well, and we're always open for improvements and criticism as well, I do think we also sometimes maybe need to introduce the psychologist earlier. Where do you pick up the warning signs before it's too late, and you completely put the patient in a depressive episode, and she's struggling to get out of that as well. So, but it's information that empowers them.
Okay, and what are the costs involved, and does medical aid cover this?
So we've looked, and I think cost is always, besides the psychological barrier, cost is the biggest barrier to this fertility treatments. We know as well, the ladies we employ, our embryologists, the equipment we use, it's very expensive equipment. So this is why numerous clinics have tried to bring in what they call low-cost IVF. But again, you compromise on quality. So somewhere you compromise. So it's high-tech technology that is your inputs, and obviously this is being reflected in the high cost of IVF as well. So it's always very encouraging when you look at someone like a medical aid that think, let's support our patients, let's help them. Because if you look at fertility care, according to current medical aid rules, infertility care is a prescribed minimum benefits. So they're actually obliged to start paying for this as well. But we have been in discussion with a few various medical aid funders, and fortunately 2 of them now are already started funding for fertility care. I can name them names because we do salute them for this step. It's CAMAF, the one for our auditing firms, and the other one is Discovery. So with Discovery we had where they did a pilot project, and they did see the benefits in this as well. And now they've rolled this out to the patients receiving cancer therapy, that they're willing to pay for fertility treatment and fertility preservation for these patients as well. So we see that as a very positive step, and we trust some other medical aids will follow suit. So although this has been seen as very positive steps from the medical aid and some funders as well, in vitro fertilization still remains a very expensive treatment modality as well. And we obviously would want to get more people involved, try and get the cost down as well. But if you look at the cost in itself, the cost would vary anything from 80,000 Rand to about 150,000 Rand per treatment option. And the biggest cost of in vitro fertilization is actually making the embryos and storing them.
Okay.
So once that's done, usually by transferring them a few years later as well, the cost is much lower. Then we talk about a 20,000 Rand just treatment cycle to go and transfer embryos. So if you look at IVF in itself, what I always say a successful IVF would be is to try and generate a good number of embryos, transferring 1 or 2 of them back into the uterus, and hopefully have a surplus embryo one day to complete the family of that patient. That for me is a good IVF cycle.
Thank you, Dr. Venter. That's very insightful. IVF can be a costly procedure, but as you have updated us, there are medical aids that are now looking to assist in covering those procedures and include IVF as a prescribed minimum benefit. So I think the viewers at home will be very interested to know this information. And could you tell us, could you share some advice or encouragement for any of the viewers at home who are looking into the procedure or having fertility issues?
Yeah, the advice I will always, what I will always give is the following, is to say, do choose the center right, do choose your doctor right to give you the answers you need, because that's your right. You need to have real answers to your problem, and not just by giving you tablets and say come and see me in a year's time again, because that delays time, that delays effective treatment as well. To make sure that you get the answers you want and to go for effective treatment therapy. If you look at this journey, and this in some patients it is a very long journey, but I always tell them as well, you must look at what is the reward of this journey. The reward of this journey is a child, and that is life-changing. It's something you cannot buy. It will be life-changing. If you miss that part of being a parent in your life, a big chapter out of your life is gone, and which is a very, very rewarding chapter. So for me, the advice for them would be just to persevere and to chase your dream.
Yes. Well, thank you so much for sitting down to chat to us today, Dr. Venter. This has been such an insightful and informative interview. Thank you so much, and all the best on the amazing work that you do.
Thanks, Sai. It was really, really a pleasure talking to you. Thank you.
Infertility is the term when failure to conceive occurs, and it affects approximately 10 to 15% of couples. Both partners should be investigated simultaneously, as causes may be detected in both male and female partners. A couple should seek investigation if there is an inability to achieve pregnancy after 1 year of adequate unprotected sexual exposure. Primary infertility is where patients have never had a pregnancy or conceived before, while secondary infertility is where patients who have previously had a child now experience trouble in trying to conceive another child. The inability to conceive can be a distressing and emotionally taxing experience for a couple who need significant care, empathy, and prompt investigation of their problem. Getting pregnant and carrying a pregnancy to term are actually very complicated processes where a number of things could go wrong and thereby lead to infertility. The most common overall cause of infertility is failure to ovulate, which occurs in approximately 40% of women who present with fertility issues. We are here to learn more about this topic. Joining me now is Ms. Candice Botha, who is a product herself of in vitro fertilization, commonly referred to as IVF, and she has undergone the process herself, giving birth to a pair of twins. Thank you so much for joining us today.
Thank you for having me. I really appreciate it.
So, could you tell us a bit more about your birth and when you found out that you were born through in vitro fertilization? How did that make you feel?
So we've always had a very close family. My family and my friends, we've all just been very close. And when I found out that I was having twins myself, and having known that I was part of a quintuplet, growing up, it was seen as normal for me. Not too many people around us, and we were called test tube babies when we were younger. So it was quite a shock to get used to initially, and then I think once I learned about the process, having done it myself and going through it, it sort of gave me a new respect for my mom, and just figuring out how life was when we were younger. It was an amazing experience to have to go through what my mom went through as well. It was great.
So both you and your mom experienced difficulties in trying to conceive. Can you take us through some of the challenges you faced and the reasons behind you not being able to conceive naturally?
Yes, so basically what happened with my mom was she had hormone issues like I did. So I had a feeling that it would happen with me as well. So when my husband and I decided to pursue having kids, I knew that my first step would be to go to a fertility clinic. So my first step was going through artificial insemination, trying naturally, doing things before IVF, because I didn't think I'd need to do IVF. I thought perhaps there would be an issue, but I didn't think that there would be, an IVF issue. Yes. And then when it got to a point where we exhausted everything we could, we did the IUIs, we did natural, we did planned, everything. Then when I came here, they said to me, the last resort is IVF. It was very heartbreaking, but having my mom gone through it, I had someone like a soundboard to discuss it with. Sure. So it helped a lot. It was now looking back on it, it was a bigger deal than I thought it was at the time, but I just sort of had someone to talk to about it, which really did help.
Now, you've mentioned something very important there about having someone to talk to. So could you perhaps tell us a bit more about pressures you may have experienced, any stigmas that you experienced, and did you have support?
Yes, infertility is seen as this big red dot on you, and I felt that it was incredibly important to discuss and to have friends that are going through the same thing.
Yes.
So I was admin of a lot of Facebook groups, and actually one of the central people that I would discuss my journey with anyone who'd want to listen to me.
Yes.
Whether it's someone sitting in a car park or someone on Facebook, I made sure that I had my WhatsApp groups and my Facebook groups, because you need to be open about it. It's the most important thing. You need to cry to someone. You need to laugh with someone. Yes. You need to say, today I'm struggling with my injections. I'm worried about my embryos. I'm worried about the next step. It's so important that you have your friends, your family, even people who are in a different country or for me, different cities, who I've now become very close friends with. It's important to have those people to always discuss with, even if it's just the smallest thing. It gets you through every single day. I mean, it's not an easy journey, and I would take my hat off to anyone doing it now. It is very difficult, and I'm still very, very involved in those groups to this day. If people ask me about infertility, I will tell you my journey from start to finish 10 times over. If it gives someone a little bit of hope and a little bit of encouragement, that's really the most important thing to me.
Well, definitely, having undergone the procedure yourself, you would be the perfect person to support someone else and give advice to someone.
Yes.
And could you take us back when you decided you wanted to opt for IVF? Was it a decision that was difficult to make? Tell us a bit more about that.
So I even remember sitting here and them saying to me, unfortunately, we're going to have to take a 4-month break and your only opportunity to get pregnant is to do IVF. And initially I thought, oh, okay, IVF, I am an IVF baby. That seems normal to me because it is just how I came about on this world. So, why would it be weird for me? But the closer it came, it was very difficult, but it was a no-brainer for me. I would give my left arm to have a child. So I would do whatever it took. I'd throw any money I had to do it just to have that baby. So it was difficult, but I just knew it. At the end of the day, I'm an IVF baby. My mom had success. I mean, she had a litter of us. It was bound to hopefully succeed. And I just went in there, guns blazing, and I thought, I'll do whatever for this little one. And which ended up being a little too. So it wasn't hard at the end of the day to decide. Yeah, it was a passion of mine to be a mom.
Yes.
When I was 12, I always said I want to be a mom. And come hell or high water, when I started working, I saved, and I never knew why I saved. And when I realized I needed to do IVF, I just knew all my savings, I will give everything if I have to, just to have that little one. And it paid off at the end, definitely, tenfold.
I think our viewers will really connect with that. Being a mother to a woman is such an important thing. And as you mentioned, the pressures involved with not being able to conceive naturally.
Yes.
Do you think that women have support structures in place for this?
Not at all. I feel that there needs to be way more support in terms of firstly breaking the stigma of not being able to have your own kids, because it happens. It is what it is. You cannot blame yourself. It could be external factors. It could be hereditary. It could be anything. Yeah. But you need to be able to just be open about it, and people need support. I mean, I feel that's why a lot of people don't go through IVF or IUI, just decide to rather not have kids because they don't have that structure behind them. And I was lucky enough to be able to find that group of friends who was going through it with me, or who I found on Facebook. I would just put a post saying, I'm going through this, who can help me? And it takes a lot of guts to actually somehow reach out to someone. And I think a lot of people are sitting there in their enclosed bubbles and they don't want to talk about it because they feel like they're going to be judged. Oh, that woman's now going through IVF. Oh, she needs to get a doctor to help her have a baby. Look at me, I'm popped out my third one. You can't take it away that they're lucky enough to have them naturally, but you can't take it away from us that we need help. And it's okay, that's all right. You've got these incredible doctors and embryologists who can do it, and we're just incredibly fortunate to be able to get it done.
And could you just take us through the process as you went through IVF? After that, how were you feeling and what was your mindset at that stage?
So it was tough with all the hormones. So, initially you've got to go through your egg retrievals and you feel like this just balloon full of eggs.
Yes.
I retrieved, I remember 15 eggs at the end.
Wow.
Considering women should only have 1 a month, I had 15, so I looked like I was 3 months pregnant and I wasn't. So I remember showing it off, look, my egg baby,
Wow.
So that was crazy. The hormones were a lot, and having to inject your tummy every day. My husband was a champion. He would break the vials for me and measure out the medicine. He was great. I got so pro taking needles, it was crazy. And then after that, it was waiting for the call to see how many fertilized. I remember coming in here when we had to do the egg retrieval. My husband had to go give off his sample. Oh, we love telling that story every time because it was the most awkward thing for him to have to go into a little room on the side. But he got it done. We got our 7 embryos frozen at the end of the day, and we were very lucky to have 7 out of 15. I mean, that's usually it's a lot less. So we were lucky we had 7 chances to have a baby, and we had to go into a frozen cycle because hormones were very intense at that point. So you have to wait for your body to calm down a bit, and then you can go into frozen transfer. So then we did that in, I think it was May 2017, which unfortunately ended in my first miscarriage, which was really tough. I did fall pregnant.
So sorry to hear about that.
It was okay. I remember my husband was away on work and I had to go through it with my mom. So she brought me here. We went through all the beta tests, and it came out that I had miscarried, and it was really, really hard, but thank goodness I had my mom, and she made me this ridiculous chocolate pudding that I'll never forget.
Wow.
She just fed me chocolate, and you know, the fact that she had been through it, she had a miscarriage before she had us, so it was like history repeating itself in a sense. And I got myself up, picked myself up, and I came back here a week later, and I said, I want to go back again. I don't want to miss a cycle. I don't want to wait 6 months. I want to do it now, like now or never. And I would sit in the office with the doctor, and he says, you know, I'm really sorry we didn't help you get pregnant. I will never forget him say that. It was the most heartwarming thing to hear from a doctor. I'm so sorry you didn't get pregnant this month, because so many times I went to my first infertility specialist. They were like,
Yes.
so many people got pregnant this month, and I'm like, thanks, I didn't, but thank you. But for these doctors to say, I'm so sorry. And we went guns blazing into the next round. We tried and we succeeded, and we got my numbers, and they were sky high, and I was like, oh, twins, you know. So I was happy that I could hopefully have multiples. So it was a up and down roller coaster. Some days was great, and other days was tough. But it was worth it, definitely worth it.
That's such a touching story, and I'm so glad that it eventually worked out for you, because I can see this is something you're very passionate about.
I'm probably overly passionate about it. So, you know, if I didn't follow the career I'm in, I think I would have gone into the embryology. Had I known about this, I would have, because for me, it's just, infertility needs a voice, and I'm someone who's very passionate about making sure the women that are infertile, unable to have kids, have that voice. It's so important. You know, you need to say, hi, I am 1 in 8, I am 1 in 4. And that to me is important, that then people will be like, the amount of people who put their hands up and say, I've tried this, and I'm not succeeded. It's incredible the amount of people who can say they have done it. So yeah, if I can make one person hopeful, that's my job done. So
That really does sound amazing, and something you mentioned there really touched me. And when you mentioned that your husband was involved in this whole journey,
yes.
Do you think that there are structures in place for men to be more involved and educated about this? Because it is a couple
Yes.
issue. It's something that both partners should be involved in together.
That's true, because most of it is the females focused on the mom, you know, is getting her womb ready, is her lining fine, but no one really notices in the background, there's the husband. He's actually the pharmacist. He's the one giving the medication,
Sure.
you know, he's the one measuring things. And there isn't enough. I think they're going through just as much emotionally as you're going through, not physically, but the emotional toll is shoved onto them. And they have to be the structure, the rock solid guy. They have to be the ones holding up the woman's emotion the whole time. So I feel myself personally haven't seen a male only, you know, the husband side of the pair, because that actually should be important, because they're the ones that are putting up this front the whole time. Oh, I'm strong, I'm the man.
Yeah.
My wife's, you know, she's the one doing everything. I've got to be strong. And that's just as important. If you don't have that strong figure behind you who also needs his support, he's going to break at some point. And you see it, how in their face, how hard it is to watch you go through it. And they're struggling as much as you are, even if they're not the ones with any issues. It's difficult.
Well, well done to the both of you for being a part of this together and for supporting each other throughout this journey. Now that you have undergone the IVF procedure, could you tell us a bit more about the birth of your third child?
Yes, my little Liam. He is our little miracle child. I mean, I was told by how many doctors that I could not have my baby naturally. I would always have to go through fertility. I've got embryos frozen, so I'd have to do another frozen transfer. So I sort of resigned myself to the fact that if I did want another one after twins, I'd go through an FET, my frozen transfer.
Sure.
So during the pandemic hit 2019, I thought, okay, we'll see how it goes with the twins. They were still young. We'll decide, because it was mayhem that first 18 months for the twins. I don't know how I survived. It was insane. But I think the fact that the world sort of slowed down a little bit, we worked from home, things were just more calm, and we weren't trying for a third baby. I wasn't in any way, shape or form preventing it either, but I didn't think I'd ever be able to have my baby myself. So, you know, you just carry on as normal. It is what it is. And the one day I'll never forget, it was a winter's day in May, and I took a test, and I messaged my husband and I said, you won't believe this, but I'm pregnant. And his first reply was, oh, we should probably look at our savings then and change our car. Oh my God. He was shocked. So I even sent a video and I'm like shaking in this video.
Wow.
And I was shocked. And my number started low. With my first miscarriage, it started at 9. And now this number started at 9. I'm like, it's history repeating itself again. I'm going to end up in a miscarriage. I'm not even going to get excited about it. Then the numbers started quadrupling, not doubling when they should be doubling, it quadrupled. Yeah. So it went 9, 36, 124, and I'm like, okay. And I remember the 4th beta we went, I got home and I said, so love, I'm at 409 now. He's like, he looked at me with his white face and he said, so you are pregnant? I'm like, mm-hmm. So initially it took us about 2-3 months to get really excited, but the fact that we could fall pregnant naturally after IVF, I mean, the statistics say that 62% of IVF pregnancies do end up in a natural pregnancy. So it's not always, but I was one of the lucky few. And I've got about 3 or 4 friends it's happened to as well. So the fact that it can happen, it was amazing. He's our little miracle child. He is our pandemic baby. He owns the world at this point in time. He's so chilled. He is so calm. Nothing bothers him. He is very chilled. So we're so blessed to have him. And the fact that I still have my embryos if I really ever wanted a 4th one, but I'm just lucky that I didn't have to go through the process again. And he's just a little walking miracle. It's amazing.
That really is a miraculous story, and I think your story is something that's going to give other women and other couples, men and women, hope and courage, should they also feel that they are going through the same journey. What words of wisdom or words of encouragement do you have for couples who are having difficulty conceiving naturally?
I think the most important thing is go see someone that knows what they're doing. Like, if you feel like you are struggling, don't sit and wait for another year because you don't know what the problem is. Go and get the help. It is so important. That, and just don't be ashamed. Don't be ashamed to put your hand up and say, you know what, I might have a problem. It's okay. You know, there's so many of us, and the community is incredible. The support that I've got from the women is amazing. So put your hand up saying, I am one of them. Join a Facebook group. There are so many Facebook groups and WhatsApp groups, and you know, talk to me. I love listening to the sound of my own voice. So I'm here to encourage anybody who wants to listen to me ramble on for hours. It's important to say I'm here. I want to be seen. I want to be heard. And I want help. And there's incredible doctors who will help. So it's just take that step. Don't wait. That's important. Don't wait.
Well, thank you so much for sharing your amazing and heartfelt story with us, Candice. We wish you well, and it's been an absolute pleasure talking to you.
Thank you. I appreciate that. Appreciate the voice. Thank you for having me.
Sure. Children are a gift and a blessing, however they may arrive. Please be kind to those who are struggling to conceive and rather refer them to labs like Vitalab. You can follow us on Facebook, Instagram and YouTube at the African Essence television show. And from us, it's good night and God bless.
Igama lami ngugogo Virginia Dlamini. Ngingumlimi omdala womoba kwaHulethe eKZN. Ngineminyaka ewu-91. Ukulima umoba kade kwaba ingxenye yempilo yami. Ubaba wayelima umoba, nomfowethu wayelima umoba, nami futhi ngilima umoba. Ngibona abesifazane abaneminyaka ewu-60 besebenzisa izinduku, kodwa ngisakuthanda ukudansa nokuhleka eminyakeni yami. Vele ngisazizwa ngimuhle. Umphakathi nawo ubalulekile kakhulu kimina. Ngichitha isikhathi ngisiza umphakathi ngezingxabano zomhlaba kanye nokuphatha amalungu ethu esibambisene nawo. Ngifundisa ingane zesikole nomphakathi wonke ngokubaluleka ngokunakekela umhlaba wethu. Kuyangizuzisa uma ngibona abanye bekwemukela ukunakekela umhlaba wethu. Kuyangizuzisa kakhulu uma ngibona abanye bekwazi ukubona umthelela omuhle ezolimo ezinawo ezimpilweni zabo. Ngiyazifela ngomhlaba wethu, ngiyazifela ngomphakathi wakithi, ngizifela ngokukhulisa ikusasa elimnandi.
ARCA Durban provides an exclusive rehab treatment for alcoholism and drug addiction. The only rehab in South Africa that offers a medical detox treatment. We offer a superior, evidence-based and medically cutting-edge approach to the treatment of addiction. If you have been frustrated by repeated failures at rehab recovery or are unaware that there are proven anti-craving medications that can significantly improve treatment outcomes, give us a confidential call to learn more about ARCA Durban's rehab program. Contact ARCA Durban on 07827229111 24 hours or call our office number 031-261-5515 and our Johannesburg number on 0622770911. Office number 011-656-0705.